The broadcast is now starting. All attendees are in listen-only mode.
Welcome, everyone. We are glad to have you here. We're going to give the system just a minute to let all the attendees get loaded up. And then we're going to launch right into this. So my name is Norm. I'm the Executive Director for the National Association for Health Data Organizations. And we're very pleased to have you join with us today on this special edition follow-up to our web conference that we had last Wednesday on COVID-19 and health data. Today, our panelists will be Mary Jo Condon from Friedman Consulting, Melody Kraft from Milliman MedInsight. Srinivas Sidara is tentative. We're hoping he's going to be able to make it from Optum. And Alex Bohl will also be here from Mathematica. And I think I missed somebody, but that's okay. We'll figure it out as we go. All right, so let's go ahead and get started. We're going to turn the time over to Mary Jo Condon, who is going to introduce the topic for today and talk to us. First of all, we're going to talk about coding and tracking COVID cases. So Mary Jo, let me make you the panelist.
Mm-hmm. All right, Norm, can you see my screen okay and hear me okay?
Yes, looks good.
Great. Well, good afternoon, everyone. Welcome to today's web conference. We really appreciate you taking the time. We know this is an incredibly busy time for everyone. What I'd like to spend a few minutes talking through with you today is essentially if you want to kind of DIY, do it yourself, building an episode of COVID-19 care in your claims data, how would you do that? So there's a few questions that we're going to answer today. One is, how do I find cases of COVID-19 in my claims data? What diagnosis code should I be looking for? What analyses can I perform? As I mentioned, kind of how do I build that care episode? And then are there some analyses that I may be looking for other data sets? And that's mostly going to be a topic that we move to in a future webinar, but we will just kind of briefly touch on that today. All right, so finding the cases. So as many of you may know, a new diagnosis code specific to COVID-19 is expected to be released in October. Until then, the CDC has made the recommendation that providers use B97.29, which is described as other coronavirus as the cause of diseases classified elsewhere, and that they use that in conjunction with the code for the reason for the encounter. So pneumonia, acute bronchitis, cough, and we're gonna, in just a minute, give you a list of those codes so that you have them, and you can use that list to begin looking in your data, at least obviously not post COVID-19 crisis, but at least you can begin to kind of build those queries. So when the new data is available, you have it ready to go. I think it's, as you'll see in just a second, it's going to be really important to note that there's going to be that additional code there for the reason for the encounter, because as noted here, the CDC recommends only using that B97.29 code for confirmed cases. So suspected, possible, or probable cases are only going to be reported, or at least only supposed to be reported, with the reason explaining the encounter. So as we all know, there's been a lack of widely available testing, and there have been some testing delays. And so as a result, some related care may not include that B97.29. We also know that providers don't always code exactly as they're instructed. And so some providers may still use that B97.29 for unconfirmed cases. We also know that patients, as they seek care, are unfortunately not always thinking about what we need for our APCDs. And so they may be more likely to seek medical care for minor coughs, bronchitis, fevers, things that are unrelated to COVID-19, and honestly, things that they would not have sought care for just a few weeks ago because they're concerned about COVID. Similarly, many patients with COVID-19 are going to have mild cases and will never seek care and therefore will not be documented in claims. Okay, so codes to explore. I'm not going to read through this list with you, just want you to have it for your reference. Norm's going to send out the slides. You're also welcome to take a screenshot of it. But essentially, we're recommending that analysts review potentially related diagnoses with and without the B97.29 code. So this is a list of diagnoses where we're suggesting that you start. This list comes from guidance from the CDC. Okay, so what do you do once you find these diagnoses? Well, you may want to look at cost and medical cost and pharmacy cost and utilization related to the episode, and we'll talk in a minute about building that episode. Trends or commonalities among patients that need more intensive care and services. So are they of certain age or gender, or did they have certain pre-existing comorbidities when you look back in the data? Future care patterns. One thing that we don't know much about at this point is what is the long-term impact of a COVID-19 diagnosis? And we think that over time, APCD data will be very informative in answering this question. We also know that there's an increase in use of telehealth services right now. And we've listed there for you 2 links, one to an AMIA guide that has come out, and also another to a blog post that we've written that talk to you about how to look for telehealth services in your data. That may also be the topic of a future webinar, but just wanted to make sure that you had those resources today.
Hey, Mary Jo,
okay.
just real quick,
Sure.
we had a question come in. So the U07.1 code has just, apparently that's going to be available on April 1st, 2020. Are you familiar with that? Can you comment briefly on that?
The U07.1 code.
It was recently released at the ICD-10 CNM meeting. So maybe that's just something that has late breaking and we can add to our list.
Yes, I think that's absolutely right.
Okay, very good. Continue on.
And so the first thing that you'll, and I'll be looking into that immediately after this, believe me. And so the first thing you'll want to do is look at healthcare utilization related to one of those diagnosis codes. You'll also want to be looking at healthcare utilization for folks who have had a COVID diagnostic test, and so you'll see those codes there. And then the second part of that process of building that episode is really thinking about what do you want the span of your episode to be. And so the first piece is going to be, you know, do you want it to be anchored by a particular service, such as a hospitalization? I think Dr. Kraft is going to walk through how that could look in just a few minutes. And sometimes you're going to want that anchored service to include a period of time before and or after. Or do you want it to be for a specific length of time, like 30 days or 60 days? Your analytical question obviously should inform your episode span. And so folks who build episodes already, maybe you're building it for a joint replacement or you're building it for a year of care for diabetes, typically something that is discrete, like a joint replacement, would be anchored by a particular service. Something that's more care for a chronic condition may be anchored by just a period of time. And I think although most of our early analyses in this realm are going to be anchored by particular services, whether it's an office visit, hospitalization, ED visit, over time, we may be looking more at kind of these lengths of time to, as I noted before, try to get a sense of the long-term impact of this diagnosis. All right, so which diagnosis codes should you include? As noted here, the index event diagnoses at the beginning of this presentation are a great start. Sounds like we have another one to add to our list. And honestly, this is going to be changing quickly. And so We're going to be continuing to keep our list, or at least try to keep our list at apcjournal.com up to date. But we do expect there's going to continue to be changes and edits to that. The other challenge sometimes is that as your episode lengthens, it can become more and more difficult to determine what should be included and what should be excluded. So we wanted to just kind of give a couple of tips for that. One is, do your research, right? So literally new information is coming out each day on the course of this disease and the care that's needed to support patients. So we can't honestly say today what is the right bundle of services to include in your episode and what's not. I think that this is going to be evolving. That being said, you can start as your data comes in to look at descriptive statistics in your own data. What trends in utilization do you see in patients with one of those index events and diagnoses, particularly those that have a confirmed case? And then stakeholder input. So I think it's always really important to develop a draft and share to gain input, and also develop a process to adjust this over time. This is such an emerging area that it's going to be evolving and evolving quickly. And so don't be afraid to circulate it across public health officials and physician leaders in your state and get their input on the best next steps. All right, and there is just some more information to reach me if you have any additional questions.
Okay, well, let's go ahead, and I don't see any questions coming in at the moment about the presentation, but there may be more. And by the way, on the questions, if you have questions, put them in the question bar and we will queue them up and give them to the presenters. So let's then turn the time over to Dr. Kraft to talk more about some of their experience at Milliman Med Insight regarding coding and tracking.
Okay, so Norm?
Let me make you the presenter.
Okay, perfect.
I just got to make sure, did I get the right one?
How's that?
That looks great. Thank you.
Okay, terrific. And I apologize, everybody. I'm losing my voice. So the good news is it is not COVID-19. I can tell you that. But I'm going to just try to speak to you today, and hopefully you can understand me. So my name is Dr. Melody Kraft, Director of Strategic Analytics Services and Research at Milliman Med Insight. And I'm here to just share a few thoughts with you about how we might analyze episodes of care regarding COVID-19. Later on in the presentation, I'm going to be joined by Dale Skinner, who is one of our senior consultants, our information technology consultant at Med Insight. So, there's caveats because the field is constantly changing. And so the information I'm providing here is to the best of my ability, but it is literally changing. Gosh, it seems by the hour, but certainly every day. So we thought to start with how we're going to explore. Now this does follow on from the presentation I gave on Wednesday, where we had a lot of tables that detailed out the codes. So I don't want to recap too much of that. We'll just start there and then move forward. So I wanted to think about what might be the clinical services involved in an episode. We want to give you a little bit of an example of an analytic process, an analytic approach. And then I did want to share with you some new information that I gained. And there's suggestions to improve the capture of ventilator utilization and identify those ventilator patients. And then finally conclude with some of the challenges in doing this. So complexity, ambiguity, delay. So it's quite difficult to do. So this is a quick recap. You've seen this information before. So there's your U071 code, Norm, that you were mentioning is the new one that is not actually to be used until April 1. But then the CDC does recommend those two codes in the middle. The one that Mary Jo was talking about, B97-229. so that other coronavirus. And in fact, that code is being used in association with other indirect diagnoses such as pneumonia. And then there's an additional one, the J1281, pneumonia due to SARS-associated coronavirus. And I've given you a link at the bottom here. That's the CDC source information, so you can see for yourself, all of the detail there. This is a quick recap. You've seen this before, so those are indirect diagnoses. So a number of reasons you might want to do this. First of all, that direct diagnosis, the U071, is not out until April 1. There is always a little bit of ambiguity in the symptoms. It's a very varied presentation from patients. And then, quite frankly, there's some things that are not definitive. So we talked a little bit about the fact that a negative test doesn't necessarily exclude a diagnosis of COVID-19. So up here, just to orientate you, we've got our non-specific diagnoses, cough, fever, shortness of breath. Then we've got all the respiratory infections, anosmia at the bottom. On the right, we've got respiratory failure, and then going to cardiac failure, renal failure, and septic shock. So,
Melody, we have a question real quick. If you could just go back to the previous slide.
Oh, sure.
So the question is, so a lot of folks who have the coronavirus, who've been infected, will never be tested, and so we won't ever know if they tested positive or not. How can this information on this screen be helpful in kind of estimating or guesstimating the total impact, knowing that a lot of people will never be tested?
I can't answer your question because I mean, by definition, you just told me that we'll never have a positive confirmation. I mean, if it's just a delay in testing, it's something to keep in mind, right? I've realized that testing is getting faster and faster, so I hope that that will improve. But you still hear stories of it being 4 days or more. So if you're having to deal with a patient and you're not sure, these are just some of the things that perhaps you could consider.
Okay, because we are hearing, I've heard of stories of people who have symptoms, but the clinician is just saying, well, you probably have it. In fact, you almost certainly have it. And we only have so many tests, so we're not going to use one of those tests on you. So just go be treated and just believe that you have it and act like you have it. So that's kind of the data, isn't it?
Yeah, the percentage of the population that's being tested is dramatically different in different countries. And I think we know that.
Okay.
I'm going to move on if that's okay.
Yeah.
So this schematic is trying to help us think about all the clinical services and other transactions throughout the care journey. Now, the CDC notes that symptoms may, this is their word, may appear within 2 to 14 days after exposure based on the incubation period of MERS-CoV viruses. So we could look for the previous encounters during the 14 days prior to admission. I mean, maybe the patient went to urgent care or their primary care physician or the ED. Perhaps they engaged with a provider through telehealth, or perhaps they are an existing patient with a chronic condition receiving home health care. So I've just moved through that inpatient segment because we're going to go through that in more detail in the analytic process. But as we think about the discharge and post-acute care, I absolutely concur with Mary Jo's comments. We don't know yet about the long-term effects of COVID-19. So there are some anecdotes of significant changes in patient status after discharge. And so as more information comes in from actual experience in the US and other countries, we may get a better sense of this. But for now, our example looks at the 30 days post-acute. So I'm just gonna start through. So if we think about a gradual drill down from a high level, step by step. So first, if we take all inpatient admissions, a subset of that are going to be ICU patients. If we then look in the middle there at the patients being sent to ICU, a subset will be on ventilators. Of these patients, we can look at the CDC guidance. Sorry, I have actually lost my visibility of my screen. Okay. I have to find a place to park all the rest of the meeting dialogue, Norm. Okay, that's better. So the patients on the ventilators, we use the diagnostic codes, particularly the ongoing evolving guidance, to help us narrow down to those who are actually most likely to be COVID-19 or indeed are confirmed positive. And then of those, at the bottom there, you see we can look at some of those associated diagnoses. They're serious. They're causes of morbidity and mortality for these patients. So of course, acute respiratory failure, and that's largely why they're on a ventilator. But there's also acute cardiac injury, acute renal failure, and then the extremely dangerous septic shock. In fact, more than that is multiple organs failing. So that is how we're kind of thinking about stepping through the analysis, and then we look at the outcomes thereafter. So those who unfortunately did not survive, and those who did, made it through step-down care to hospital discharge. So perhaps you might want to break it down further and look at those who are discharged and see what were the diagnoses, some of the causes perhaps that were associated, and the same for those who expired. What was happening with them? Are they any different from the patients who survived? So I'm going to hand over to Dale for a moment and sort of rest my voice. Dale, would you walk us through the analytic process, please?
Sure. Contrary to what the video caption says, I'm not Dr. Melody Kraft. This is Dale Skinner. I'm the technical lead on our MedInsight Strategic Analytics Services team. What this slide 19 is showing you is one possible approach to building one of these episodes. It's based on the information on slide 6, where we looked at 14 days before and going out 30 days after. And in this case, what we're using as our index or triggering event is an inpatient stay of interest. Maybe that's a confirmed COVID diagnosis, maybe it's presence of one or more of the indicative diagnoses. Depends on what you want to look at. For each of those stays, you want to find the admit and discharge date for that stay. Then you want to look at services for that member from 14 days before, running out to 30 days after. Do you want to look at all their services in that range or just some? Again, depends on what you're doing, and what kinds of things you're going to want to look at are certainly going to be evolving as this progresses. You're almost certainly not going to want to look at everything. There'll be some noise in there, like people who get who are on maintenance scripts from a mail order pharmacy automatically every 30 days. That's irrelevant for this. But there are many things that you are going to want to be looking for. Inpatient readmissions, obviously, emergency department visits, probably follow-ups to PCP care or urgent care. Looking on the other side, the things before the admit, similar things you'll want to be looking for there: ED visits, urgent care visits, contact with PCPs, your telehealth probably. Basically anything that you can hang a hook on that indicates they may have been suffering from symptoms before they ended up in the hospital. Once you've lumped together all these pre and post services, you probably want to break them down in some way by service type or number of days before or after, maybe a combination of those. What are you going to want to summarize? Again, depends on what you're looking at. You may be looking at just utilization. How many visits, how many scripts, how many days supply of a med, something like that. You may be more interested in the financial impact, where you'd be wanting to look at billed amount, allowed amount, paid amount, cost sharing, etc. Or you may want to be looking at relative value units. That can be a proxy for your financials if they're not available for some reason, but also can be interpreted as a measure of the intensity of their utilization over these periods. One other thing you may or may not want to include in the episode would be the professional services that actually occurred while they were in the hospital, the E&M services and that sort of thing.
Okay.
Hand it back to the real Melody now.
Oh, it's all right, Dale, you can continue. If you This is a quick screenshot from our portal. So as Dale was conducting exactly what he described, this is a little bit of the work in progress there. I did want to share with you a little bit more information on capturing ventilator use and ventilated patients. So we looked at this last time, okay? And we talked a bit about the total ICU capacity. So that's where we had all categories of ICU here. It's not specific necessarily just to COVID-19. But down below are the ventilator codes. And what I wanted to share is that on the right-hand side, those HCPCS codes aren't generally reported for inpatient. And so perhaps the better codes that I would suggest are those for intubation. So the endotracheal airway insertion and respiratory ventilation, those ICD-10 codes are really, we found, they're gonna improve your capture. So just in our preliminary, very preliminary tests, that's what we're suggesting to you. Okay, and then just now to wrap up by thinking about the challenges here. We know that the symptoms at the early stages are non-specific, and they have a broad range of differential diagnoses. We know that there's a very varied clinical spectrum, anything from asymptomatic through mild to moderate pneumonia, severe pneumonia, and then you've got acute respiratory syndrome, sepsis, multiple organ failure. There's hypothesized that there may be a potential delay in claims submissions, and that could be due to a shortage of workers or just the overload on the system in general. And then these long-term complications of survivors of COVID-19 aren't yet available. So we're learning as we go along. But those are just a few of the challenges, and there are more. But I just wanted to get the conversation started. So that's it from me, Norm. And I would really welcome the dialogue from people.
Let's do this. Let's bring in Srinivas next. Let me just see.
Norm, we have a question.
Oh, we do have a question. Okay, let's do the question, then we'll bring in Srinivas. Okay.
Okay. The question is, could we look at trend lines for influenza and pneumonia and estimate differences over time that could be indirectly attributed to coronavirus?
Yes, and I think the other thing that you may want to do is, so pneumonia is another public health reported condition, right? And so, you know, one thing that you may want to do is match what you're seeing in your claims data on pneumonia up with the public health reported cases as well. But I think absolutely, and I think it's not just for pneumonia. So, you know, if we see an increase of people presenting with cough of 500%, you know, differential than we've had over kind of stable in the past 5 years, we know that it's not just that, you know, 500% more people had cough, right? So I think kind of we're going to have to see what the data looks like to try to parse that out. But I think absolutely looking at previous normal year-to-year variation and then comparing that to the variation that we see between the past 3 to 5 years and this year is going to be one of the real values that APCD data and other health data can bring.
Mm-hmm. Yeah, absolutely agree with that, Mary Jo. And I think last time we talked a little bit about, we shared some of the diagnoses for pneumonia and other conditions with the exact thought in mind that you do a historical look back and then you can compare trends.
Yeah, very good.
Yeah, I did. Thank you for it.
Let's go ahead and Srinivas, if you could take yourself off mute. There we go. And let's have you take a few minutes. It looks like you're audio only, so that's fine. Go ahead.
Yeah, sorry, our enterprise laptops think GoToWebinar is a foreign body that must be extinguished, so that there was no way to get on. So apologies.
That is fine.
And I'm a late ad, so no great slides like the rest of the group. So hello to those of you I've worked with over the years from the Maryland APCD. I think Norm had asked me to just comment a bit on some of the different data sources that might be available out there, and then sort of some of the things as the other folks have been talking about, use of claims or lagged claims or discharge data in this work. So just a context for my role, I'm not engaged in any of the state activities at this time. So my teams, we have our central machine learning and AI team within Optum, and our central data teams, and also some of the research that we do around insurance products. And my teams partner with UHC or OptumRx or Optum Care, which is our clinical care delivery arm as well, along with some of the external engagements with providers, payers, and government teams. So, in many ways, my perspective is as much about how a payer or a provider might operate internally, and perhaps less so for government analysis, but hopefully useful nonetheless. So for our teams, I think we have been rapidly trying to centralize and accumulate our data across claims, clinical, discharge data, sources for supply and bed capacity, social media, you name it, to try to be able to track surveillance and be able to understand likely areas of potential demand. That is to say, increasing spread of COVID-19, and then be able to help in planning on what are the appropriate resources needed, be it things like relaxing requirements as a payer for certain, say, prior authorization or other processes, or as provider organizations trying to plan for where you need to spike in provider availability or outreach or other resources. And certainly, as was just mentioned by the MedInsight team, needs for testing or ventilators and so forth too. The other area where we've been tracking a lot is sort of the increase in, telehealth, and how do we, deploy increasing telehealth and the impact of those. So, I think the way I look at it, I think for us, obviously, we're in a position where we have some access to real-time data that we're using across some of those capabilities that I just mentioned. But I think as much we're setting ourselves up for long-term research or analysis in this area too, as has been described. And I think in addition to some that have already been discussed, I think it's sort of evaluation of outcomes and sort of performance in different states and regional variation, both based on the severity of outbreaks and illnesses to analyzing different state responses and what was indeed the spread and growth and what containment measures worked. And so I think there's really a lot of opportunity to learn there. And I think one thing that's, we're all very focused on COVID-19 understandably right now, but the impact of the systematic shutdowns that we face today also means that a lot of folks with other healthcare needs and indeed severe needs are now at risk of not getting care they need. So one thread that I would just note that I think states can actually be looking at is, what happened to overall care. And while so much of what many measures have been focused on overuse sort of in care and sort of low value care kind of items, the reality is now that we're going to face a severe underuse situation because folks are not going to be able to go get care. So what are the impacts of that, and who's left out? What are the long-term impacts of such changes? I think are also relevant in this. I think other areas might be in understanding better progression of illness and disease. Some folks asked about what about pneumonia or other sort of predictors or things that might have been looked at as not COVID or not confirmed COVID. I think some work that we're doing is trying to build the predictive models to at least point us in the right direction of where to target. They're certainly not about research or having any pristine diagnoses, but they might give us a sense of how to estimate what was the true impact of the disease spread. And so I think we've been, that works for operational sort of work, less so perhaps for research work as well. A couple of other things that I think, based on what different states have access to, either denial data or things like that, I think might be interesting for you to take a look at what has changed. Lots of payers are thinking about changes, including CMS, for how processes work right now. A couple of other things I think that I would consider there are in actually understanding how demand and capacity actually aligned in different areas, and sort of the fallout from that, both on patients with COVID-19 who were left in or out, and other healthcare needs. And so I think, especially as states, that this then should inform how we should be thinking about capacity planning going forward, and what are indeed operational needs in states to have ability to handle. Obviously we don't expect pandemics very often, but other spikes in care need. Let me pause there. I think there's lots of topics here, but probably should leave some time for discussion across the panel and any questions that might arise.
I don't see any questions coming in, so let's go ahead and hand off to Alex, and then we'll have some time for interactive discussion among the panels. Let me make Alex the presenter.
Okay.
All right, well, look at that, it's working.
Can you
Fabulous.
see? All right, let me try to go to. Can you see the slide, or do you
Yes.
see presenter mode?
It looks like I'm seeing the slide, so we're good.
All right, thanks. I'm Alex Bull from Mathematica. I'm our Director of Data Science and Innovation in our health practice. If you want to get a hold of me afterward, you can see my email here. Just briefly about Mathematica, we're a mission-driven organization, about 1,200 seasoned experts and data scientists, among many other things, including web developers and so on. And Mathematica is involved with the COVID-19 response on a federal level by working with CMS on the federal TMSIS data warehouse that's available, as well as on the Medicare side for quality measures, taxonomy development, right? How do we capture these codes in the standard files that are created for researchers, as well as value-based payment model support. As Srinivas mentioned, many of these, the CMS is changing how they're going to set up these payment models and so on to account for COVID. On the state side, also working with payment reform like global budgets and APCD support, again, figuring out how to account for COVID. And then on the public health side, sort of adapting some of the transmission models we have for other conditions to work for COVID, and put those simulators out there, not only for transmission, but to predict health services demand. I attended the Wednesday call, which was very helpful. And as much as I'd like to say that, Mathematica is involved with all these things nationally, we learned a ton from Friedman and Milliman and others, just getting those value sets out there are tremendously helpful. And of course, even just being an attendee today, those are great. But Norm and Charles shared the survey response from the last meeting. And so we put together a couple slides here, just because we realize that some people might be now coming to the discharge data or APC data for the first time, that some of the people who are most engaged with those data sets have been pulled off elsewhere. So just a couple quick reminders of tools that are available up top here. Number one, if you want to just in general flag comorbidity or categorize procedures and you don't have a proprietary grouper, you're not familiar, some things that you could quickly pull off the shelf are the HCUP tools on AHRQ's website. And these slides will be distributed afterward for anyone who might find these useful. The next is if you're poring over those data and you want to understand potentially how hospitals are connected within systems. You could go to the ARC compendium that helps with that linkage. If you want to understand how physicians are vertically integrated within a system associated with a hospital, if that helps your response, that kind of information is also available in the compendium as well here. So that's a nice resource to support your research and understanding systems and how hospitals are linked together. Of course, there's a ton of COVID data out there and a ton of dashboards, and we'll talk about that in a minute. But I just want to encourage everyone to understand that basically the most trusted source right now on a county level is the Johns Hopkins data. It seems like the federal and state and all responses are trying to funnel resources there. And so if you're interested to know about their data, we link to their GitHub site here. However, for anyone who's looking to link that to their own data sets, and we'll talk about that later about why you might want to link that information to your hospital discharge data, we encourage you to think about the curated data that's either on the Google Cloud Platform or AWS. A benefit of using a curated data set is right now Johns Hopkins can change their schema or data can go in and out. And like real-time claims, every day and sometimes multiple times a day, those data are being updated. So the nice thing about going to a place like Google Cloud is that they're handling the changes in the data schema, and then they're creating a consistent format, and it's all very well documented. And if you're comfortable and able to work in Google Cloud or AWS, these are useful resources to go to. And at this time, AWS and Google Cloud are offering either free compute and storage, and sometimes even dashboarding capabilities if that's of interest to you. So the next thing to talk about is, I think I really liked the discussion about the coding and looking ahead to define episodes. But there are things that you can do now, and some people probably are already doing a lot of these things, but it's not too late to look at your historical or the data that you have now in a pre-COVID world to do the simple things of counts and amounts and analytics. If you're focused on a state planning perspective, of course, there are surveys out there and public use files that you can find that have mapped ICU beds and vents, et cetera. But I'll be honest with you, it might not be a bad idea if you're sitting on that data to go look at that empirically. Not for ICUs, but I was on a call earlier with someone from University of California, Davis, that if you were to look at surveys, most hospitals would say that a lot of hospitals say that they do VBACs. Again, a very different issue, but if you were to look in the data, very few hospitals actually do the VBACs in practice. So it's not too late to look up ICU stays to understand capacity as well as ventilator volume in your data, just to confirm and just to understand what you're seeing. Note that sometimes if you can't the Milliman team's presentation clarified earlier when they showed HCPCS the other day. I want to mention that you could probably approximate this with MSDRGs if you don't have those, but actually I would say that the ICD-10 codes that they presented are actually more useful. But you can also get a decent approximation just by looking at Medicare DRGs. A lot of these ideas, again, I'm just quite honestly taking from Friedman's consulting's slides earlier in the week that look at elective surgery volume reduction, as well as what Milliman showed earlier in the week on those services that might change. Those are going to obviously have dramatic implications for volume and for an individual hospital, of course, revenue and so on, but it's going to completely change the case mix. The next thing is there's something quite simple of basically admission source and discharge destination. Where are your patients coming from if you have that information? In the Boston area where I am, of course, now there are Mass General Hospital or other tertiary care hospitals are saying we just aren't going to take patients and transfers for certain places. So it's of course disrupted the network. So if places haven't had those conversations already, or if they need to prepare to have that conversation to say no, they might want to look at their admission source to understand how many transfers for selective procedures, et cetera. But that can just, again, get a quick count for planning. And the same thing for discharge destination. As you can imagine, a lot of post-acute care settings are housing our most frail and vulnerable patients. Their doors might be locked. So by looking at this, you might get a sense of needing to create those relationships with home health or long-term services and supports providers that are providing care in home or hospital and home type settings. Then looking down further, this is also a time to just take a quick look at hospital-acquired conditions. As we know, these conditions can prolong length of stay, but get a sense of how often that happens in your ICU patients, oftentimes from an AHRQ quality indicator or sometimes a CMS perspective. ICU patients are removed, or just patients are removed from the denominator from these measures. But that's from a payment reform perspective, but the reality of the quality improvement perspective and the operational perspective, it would be good to get a sense of how often these things happen and what type of patients they happen in, even though they're rare, and understand how they impact length of stay, because that continues to be something that's important to manage. And then lastly, review payer and social determinants of health data by linking your data to zip codes, et cetera, by zip code to other social determinants data. The ability to understand where your patients are coming from and what the support that they're going to need once they leave the hospitals are critically important. And of course, there are tons of open data sources and tools and so on to help you with this. But that'll get a sense of what the hospitals, the toolkits that hospitals will need to successfully discharge patients, not only COVID, but non-COVID patients. From an analytics side, I think a very important opportunity here is to link the Johns Hopkins data to predict demand. If you, earlier in the week, organizations were talking about the conditions that that make patients particularly susceptible for needing admission and going into an ICU. And so you can get a real-time prediction looking at your historical data to understand not only in your areas of what areas you're serving and populations hospitals are serving, but then figuring out where they might go based on your historical information. Next, of course, modeling length of stay for ICU and vent patients in general, just to get a sense of throughput. A major concern is when is the tipping point for capacity. Of course, there are a lot of complex tools that are out there, and I'll talk about those in a moment of what can be shared and what you can use for planning. But again, just getting a sense of length of stay and what are the drivers of length of stay in the ICU just gives you an understanding of that throughput of that critical part of the hospitals and of all the system. Again, building risk models for comorbidities with patients with similar conditions. This was talked about earlier with using influenza or other SARS, but even this could also be pneumonia, just to understand what the risk profile looks like. Trying to get a sense of any repurposable beds. Of course, we're talking a lot of times about repurposing hospitals, but just to understand what beds might be vacant, even if they were typically set up for other types of care of what elective surgical patients that might free up some capacity, not only for COVID, but for non-COVID care. And then, of course, modeling the necessary care pathways. We mentioned this before, but patients are going to need to go elsewhere, whether it's COVID or non-COVID, and just making sure you have an understanding of that network and where patients are going to go once they leave the hospital. Thinking more broadly on claims-based quality measures, I know that the federal agencies are really thinking through right now what's happening for measures, and of course, but regardless, a lot of agencies might waive reporting, but still a lot of hospitals and systems are using measures for monitoring and surveillance and reporting in general. And so just to hypothesize here, for the ARC quality indicators, which you might be familiar with as the patient safety indicators, the inpatient quality indicators, or the pediatric quality indicators, and as well as other claims-based measures, such as the 30-day readmission measures and so on. I mean, the obvious thing to say here is that volume is most likely going to decrease. Many of these focus on surgical conditions more than medical. And while medical conditions might make it into the hospital, you can imagine that a lot of these elective procedures are going to go away. And so what is this going to mean for your measures? Obviously, these agencies and the measure developers are going to have to think through what this means and how to account for COVID. But if you're starting to run reports on your data and seeing some anomalies, expect it. Because of course, case mix is going to dramatically change. On the ARC area-based quality indicators that are the prevention quality indicators that really make their way into a lot of the measures that are used, that they really serve as the backbone for NCQA measures and other measures that were adapted for different populations and might be used for population health measurement or ACO reporting. Again, that as Srinivas just mentioned, that volume is most likely going to decline, or the coding is going to show up different. Of course, there are going to be coding guidelines, but if a COPD patient shows up with over time, maybe 3-4 months from now, and they again ultimately have COVID, we're just going to see diagnoses moved into different positions and so on. And so long story short is these ambulatory sensitive conditions might be treated in under other settings. And so it might be an idea to figure out how the hospital can figure out how to triage those patients to the extent possible for care elsewhere. So lastly, Mathematica is working on a curated list of data dashboards and resources. Our inboxes are all flooded with information and press releases. And in some ways it feels like we're not doing enough, and in some ways it feels like everyone's doing a lot. And that's true. There's obviously an amazing amount of work being done, tons of data dashboards and resources. Mathematica is hoping to make a contribution and point this information at NAHDO participants and make it more relevant to them by categorizing different use cases of different data and dashboards and how you ultimately might link that with your efforts and ultimately to your data. We'll be Norm and Charles will be circulating a PDF after the webinar either today or early on Monday. But if you want to get to it now, you can go to this website. And again, the idea is that our team is working and poring over all these and trying to understand what sources have the highest fidelity and try to categorize why they might be useful and relevant to your efforts. Also, Mathematica is hoping to support NAHDO more going forward on the data and technical side to the extent possible. The post-webinar survey Norm can talk about a little bit. It'll be try to surface some other use cases that users are thinking through, and basically how Mathematica and others can help provide technical support. For example, we know that some people might not be familiar as GitHub, but a lot of code is going to be out there and might save you a lot of steps if you're able to pull down and clone that code and weave it into your workflow. Same thing with APIs. You might not be familiar with how to stream data real time, but these data, especially the Johns Hopkins data, are moving rapidly. And that might be on a cloud platform that you're unfamiliar with. And so we're trying to get a sense of that need. If there's an interest there, as well as just general needs for the discharge data you might have. But again, my contact is Alex Abel at mathematica-mpr.com. And Mathematica's team is just happy to support the effort as states and other organizations grapple this on the way forward. Thanks, Norm.
Fantastic. So we're going to now take some time and have a group discussion. We've got a couple of questions that have come in related to telehealth, and then we've got one other quick comment here that's coming in as well. Let me just read the questions.
Norm.
Yes, go ahead.
Can I interrupt real quick? Mary Jo has a comment, I believe, on Alex's point.
Oh, yes. So I just wanted to mention, I think it's really great that Alex put forward those resources on AWS and the cloud. So one of the things that we've found supporting some clients is that, you know, the unit of measurement that the data is coming in on, particularly on cases and deaths, is at the county level. And it's often being rolled up to the state level, which makes a lot of sense in most cases. But we also know that there's many regions that cross state lines, and that it can be informative for people in those regions to essentially have the data for their region rolled up to a metropolitan statistical area or other kind of bi-state or multi-state geographic unit. And so we're just taking that data off of those public sites, basically the Johns Hopkins data, and putting it into an ArcGIS that's specific to that region, that's kind of the multi-county area that represents that bi-state or multi-state region. And it's a way for folks like, I'm in Missouri, so we have two kind of bi-state regions, one on each side of the state. It's a way for them to see their data in a viewed in a format that makes more sense to them in terms of how they live their life.
Great, thank you. So let me read these two questions, and I'm going to go to Srinivas first, and then if anybody else wants to just raise your hand. I'm going to him first because he doesn't have video and I can't see if his hand is raised. I'll read the questions, go to him, and then if anybody else wants to jump in, just raise your hand and we'll call on you. Can you elaborate on examples of how you might relax rules relating to telehealth? And then I'm trying to determine originating and distant providers of telemedicine to determine where patients receive telemedicine services from by zip code. Any ideas? Srinivas, why don't you jump in first and then I'll watch for hands to go up.
Sure. I think there's actually a lot of work happening here in trying to figure out how that crosses state boundaries. So that I think probably not something I can comment on right now, but I think the other area is in changing the payment policies around that and making it an easier on-ramp for providers. That's where we focus, and I know CMS has taken some time there as well. So hopefully that helps answer some of the questions.
And do you think this is going to mess up the data, because we often think that people get care, that the provider zip code and the patient zip code, that there's some meaning for that proximity, where with telehealth, you could be 2,000 miles away and that doesn't really mean anything. Is that going to cause?
Without a doubt. Yeah, and I think, well, so I guess that there's a couple of layers to that. Certainly telehealth exacerbates the problem, but the truth of the matter is a zip code that's on like associated with an NPI is not especially useful in any case, with increasing numbers of folks with multiple office locations or practicing across clinics and hospitals and so forth. So that's already a challenge. So I think this will certainly make it even tougher to track exactly where folks are.
Mm-hmm. And I'll just chime in. Oh, sorry.
Go ahead. Oh no, go ahead.
I was just going to quickly chime in on, and then I'll let you. Just on telehealth. As you're thinking about some plans that might expand their services to include telehealth and telemedicine, and that when I mentioned on Wednesday that March 6th decision, right, from Congress that essentially waives that requisite for the originating site requirement for qualified providers. So that means that the services can be delivered in any healthcare facility or in the home. So it's much broader during the for coronavirus.
And I'll just mention there are two resources specific to telehealth in my presentation that Norm's going to be pushing out. One of them is, I thought, a really cool guide that CMS put out that essentially walks through with providers kind of how they're going to code for different pieces, and then also a blog post that we put out that explains some of these changes and links to the CMS guidance. But I will say one thing that really stood out for me, if there's one thing to know about this, is that you're also going to be able to use traditional CPT, office codes visits, and other, CPT codes that were traditionally kind of designated for an office or other traditional setting, and essentially just put on an O2 place of service code, a telehealth place of service code, and they are now going to stand in for a telehealth code. So even if you're not interested in telehealth or not interested in COVID, and you're just running your typical utilization metrics of 992s, be on the lookout for that. Make sure that your place of service code is set to give you the results you want, whether it's just services that were performed in the office or more broadly, because if you're not using your place of service code, it's not going to be quite accurate.
Okay, let's go ahead and move on to the next question here. This one has to do about whether the people that we're talking about, people have access to hospital discharge data and APCDs. Are any of those state agencies getting access to lab data from the public health? Is that pipeline open? And if so, are they having troubles with the completeness or the accuracy of that data? I don't know that I've heard that any of our health data organizations are getting access to those lab data, which is kind of why we talked about the Johns Hopkins link before. But does anybody know of anything where that's happening and is happening successfully? I'm not seeing any hands go up. So Cheryl, the answer to that appears to be probably not, but we will follow up on that and see if we can find examples of how to make that work. Is anyone engaged in or aware of any Medicaid-focused research on COVID-19 that comes anywhere close to real time? So this is maybe for Srinivas, the lag versus real time. Srinivas, I can't see your hand. I'm sure it's flying high, and then Alex after Srinivas.
Thanks. Yeah, so I mean, I think to me, the real-time applications, I think it's hard for anything with the APCDs, given just the lag of data that you get. I think for us, it's been, as you're with payers or providers who have that direct access, everything from surveillance to capacity planning can be done. Some of the lagged use cases I think I mentioned, aside from use of things like ventilators and telehealth and understanding that, is the understanding non-COVID related care, evaluation of outcomes for COVID itself, progression from other illnesses, or sort of disambiguating the COVID versus other respiratory illnesses, and seeing outcomes that play out there. So I think those are some examples that folks could consider.
Okay, Alex, go ahead.
Oh, I was just going to say, yeah, I mean, for Medicaid data, I think Mathematica is using the TMSIS data, and that's at best a month to a month, and at least a month out, and it's still based on claims. But we are for Medicaid data, there are enrollment. Yeah, there is sort of more accurate enrollment information that can be used. That's a little bit more real time, because states are submitting very frequently their Medicaid rolls to the feds to understand clawback payments from the Medicare Modernization Act. So that's helpful in a little bit. So we'll be able to monitor enrollment trends, but yeah, claims, I haven't heard of much real time other than working directly with the state.
And how real time is the Johns Hopkins database? I mean, obviously there's going to be a lag in any data source. What's your assessment of that lag?
I mean, typically, so it depends on the source, because they're aggregating so many, but there's, I forget if it's called 1 Acre 3 something. It's a group of people that's like from Facebook and Uber that put together this data stream, and that's updated multiple times a day. But it's typically everyone's refreshing overnight, and then there's also, of course, corrections that are made during the day. So I'd say at least once a day.
So it's if in our world, it's about as real time as you're going to get.
It's more real time than a claim.
Yeah, okay. All right. So speaking of claims, our next question has to do with data reporting. So this question basically says that it's really a comment, not a question, but U07.1 can be included in any position based on coding guidelines. And so it comes back to the old problem that we've had before of principal or primary diagnosis versus third, fourth, fifth, or whatever down the line. Is that just something to keep aware of, or do you think it really matters? Maybe this is for Dr. Kraft. Do you think it really matters where that code is put in? Does that mean anything, or is it just one of many things?
I'd actually like to defer to Dale, if you don't mind.
Oh, sure, that's fine. Dale, go ahead.
Yeah, I mean, generally speaking, we recommend looking at all DIAG codes available whenever you're trying to identify people with a specific condition. That having been said, I believe the CDC's guidance from a week or so ago was that if you're using that new U code, it is supposed to be put in the primary slot. But, how well providers will adhere to that, only time will tell.
Okay, great. And then this is another question about the sort of the thinking broadly impact of COVID-19. How much thought is being addressed to mental health in this epidemic, particularly to continuity of treatment for people with mental health? Has anybody done anything on that yet? Is it still too early to figure that out, or do we know?
Go ahead, Dr. Kraft.
No, Alex was going to speak. I mean, I was just saying that there's some work that has begun, but it's actually not my team doing it at the moment, so I don't want to misspeak to it. But okay. Alex, go.
Yeah.
Yeah, all I was going to say is that's it's going to be an interesting data question. We've seen the VA has opened up a lot of support services, and I believe there's a coalition of psychiatrists that were like going on and doing a lot of en masse sort of counseling and support. And so I don't know from a data perspective, but it seems like there are of course a lot of efforts. But I don't think those encounters, et cetera, are going to be captured. But there's a lot of kind of ad hoc support networks being set up in the moment.
Okay, great.
One thing I would add is who are concerned about the timeliness of claims data and maybe some days frustrated by it. Pharmacy claims are often a leading indicator of other trends that we see. And so those are going to be coming in more quickly. And so analyzing the new fills and also medication possession ratio for depression, anxiety, ADHD, I think there are going to be some early analyses that folks can tackle because those pharmacy claims are going to be coming in far faster than some of these more complex facility claims.
That's true. I wanted to comment though, the other impact here, if we're looking whether it's behavioral health or some of the other changes in services or changes in demand, is looking at the economic impact. And so with the unemployment rate hitting so high, right, we're going to have to expect some surprise enrollment shocks, right? So there are fewer insured people, there could be premium delinquencies, and so there is probably a discrepancy in the access to care. So much as I absolutely agree with what you said, Mary Jo, I don't know how that's going to impact what we would normally see in pharmacy claims and beyond.
Yeah. Okay, let's go on to the next question. This is an APCD question. It's one that we've heard many times before. Hopefully you have an answer now, but I don't think we've got it solved yet. Finding a reliable provider location in an all-payer claims database is really challenging due to billing issues and other issues. Does anybody have any tips on best practices for finding provider location in an all-payer claims database? Mary Jo or Srinivas, you want to try that one?
I would just say I think the best practice is what Massachusetts is doing, which is doing a supplemental data collection. I think now, that's kind of pie in the sky. It's kind of a dream maybe, but I do think that having a supplemental data collection around provider location and affiliation is probably the best practice. I think that beyond that, you can do a lot of manual cleaning, but, it's only going to get you so far.
Okay, Srinivas, what are your thoughts?
Yeah, I mean, I think one part of it is accepting that it's not something that anyone will get perfect, and there's problems there. Two, I think one thing is I think in states we've if I reflect back when we were doing this work, we often think that the path is to collect the data directly ourselves, and there are actually several third-party vendors of provider roster information. Not all of them are cheap, so that's certainly a consideration, but that might be worth thinking about as well. And I know that we build some of those for ourselves in Optum, but there are actually several vendors that provide that, and where there is the multiple location sort of designation, some even have the distribution of time and so forth. So I think that those could be some other considerations.
Okay, let's go on to our next question. We are hearing the possibility of variants of COVID-19, probably variants of the underlying virus as well. Do we have any insight into how that may impact the data? Will there be different diagnoses codes? What should we expect as we learn more about variations or variants? Melody, do you have any thoughts on that?
Well, so I've got a couple, I suppose. So on the one hand, the most immediate impact is it could influence the accuracy of the test, because the test is a reverse transcriptase, PCR, so it's going for something very specific. And so if there is a variant, then that's actually one of the technical issues called out as to why a test might be false negative. But if you think about the flu, right, influenza, and if we learn any lessons from that, it's a constantly evolving process, and so there's likely to be variants over time. I just don't know yet the mutation frequency at the moment. I would have to, consult the research on that, but I think it's an evolving field.
Okay, thank you, everyone. We're going to go ahead and wrap it up with that question, but I do want to point out a couple of things. One is that this webinar series has been partially funded by an ARC grant, and we are always appreciative of having that support. Second thing is I'm also very appreciative of the willingness of our panelists today and also on Wednesday to donate their time for this type of thing. And our intent has been to give you the information that you need as attendees to do it yourself, to build it up from the ground up. But if you do need help, I think, well, I'm going to just say this, all of the panelists are available. If you have questions and want to reach out to them and ask them questions about follow-up, they're all available. We'll circulate contact information. Later this afternoon, we will circulate all of the slides from both sessions that are available. We still have a couple that are in approval process, and we'll have those out by early next week. But we'll circulate contact information, slides that are available, and then Mathematica is going to have the PDF version of a resource kit. We should have that available also sometime this afternoon, and if not today, we'll have it available first thing Monday. So with that, I'm going to go ahead and wrap it up and thank everybody for your time and for your attention. We do have a brief survey at the end, which will help us develop topics for our future webinars. We are here to be helpful. We want to do what you find useful and not what we find interesting. So hopefully those things align, and we'll be able to join you again on another webinar in just a few weeks. So with that, thank you everyone for joining. Thank you to our panelists in particular.
Thank you, Noel.
Thank you.
Thank you.